ladies and gentlemen, and thank you for being here at this Fujifilm Symposium, Lunch Symposium. My name is Luigi Lunetta, and I'm head of MR and CT business in Europe for Fujifilm. Today, we are glad and honored to have very important opinion leaders across the world to lecture and to tell us something about their experience and their studies on MRI scanning. We are honored to have here Professor Shellock, who will tell us about some MRI scanning with patients having passive implants. Dr. Marlon Olimulder will tell us about cardiac scanning with MRI. And not the least, but also very glad to have you with us, Professor Juergen Biederer. We will also report some of his experience, and he will also moderate the different conversation. It is really a great pleasure seeing you all here and having you attending, and really thank you very much for participating to this event. Having said that, I leave it to you, Professor, and I wish you a nice symposium and enjoy the lecture to everybody. Thanks a lot.
Thank you very much for the nice introduction. Ladies and gentlemen, welcome to our nice walk around interesting topics in the field of MRI. And well, we will start with the most difficult topic, which is something like our everyday problem, patients turning up with implants and everything. And I'm really happy to announce Frank here, Professor Shellock, with the first presentation, which will be on materials in MR, what to keep in mind and what to do. Well, we all know you. Thank you. Thank you very much for coming, and stage is yours.
Thank you. Good afternoon, everybody. It's my pleasure to be here. It's a long trip from Los Angeles to give a 20-minute presentation, and I'm very grateful that Fujifilm allowed me to come and give a presentation to you today, and also we're able to obtain copies of my textbook for the members of the audience as well. So may I have the first slide, please? Alina? Okay, thank you. So I'm at the University of Southern California School of Medicine. We have 7 Tesla systems, 3 Tesla, 1.5 Tesla scanners, and I work with everything going from a 0.064 Tesla, which is a portable MR system, all the way up to 7 Tesla. Just so you know a little bit about my background. All right, showtime. Thanks for sticking in there with us. So just by way of background, I've been involved with MRI since around 1985. And at that time, we had the first high-field MR system in the West Coast in Los Angeles, a General Electric system. And what I was doing was I was studying bioeffects and safety and patient management and looking at the inherent problems that may have existed with high-field systems. And in order to do that, I was studying patients. And of course, patients have implants. So I had to kind of back up on my studies and start evaluating medical implants. And that started a journey that I've continued on even today. So I've essentially tested well over 9,000 different passive and active implants. And our group tests at least 200 to 300 implants every year. I get that information, I started putting it in pocket guides, and then of course established the website mrisafety.com to have a free resource of information for individuals in the MRI community. I work closely with the American Society for Testing and Materials International, the Joint Working Group, and other groups that establish test protocols to evaluate medical implants, and I serve as a consultant to a lot of implant and device manufacturers. So I really get involved with regard to not just testing, but the labeling of that information and the presentation of that content in the instructions for use. And for active implants, I work to develop checklists and eligibility forms for patients so that we have a good, concise record of what needs to be followed in order to ensure patient safety. Okay, so my presentation today, I'm going to discuss the various types of vertical field MR systems and present the physical issues that are present for passive implants and devices. I'm going to explain the testing and labeling strategy for medical implants, and then at the very end, provide guidelines for patients with unlabeled passive implants. It was interesting when I started looking at all the different vertical field MR systems that exist worldwide. I found upwards of almost 20 different companies making these systems that range from a 0.064 Tesla up to 1.2 Tesla. I'm going to confine my presentation to the whole body vertical field scanners, but realize that there are also niche scanners or body part specific vertical field scanners that are designed to image the patient's head or brain and or extremities. I'm not going to talk about those. But suffice to say, there are so many different vertical field MR systems that exist worldwide that this is a really important topic to cover, because imagine all the patients that would present with unlabeled passive implants that may be turned away unnecessarily because of some misunderstandings or just because of a lack of labeling information. You know, we do know that there are a lot of proposed and proven advantages to scanning patients with vertical field scanners, and that includes the fact that you have improved patient comfort, and as a result of that, you know, opened gantry, we have less motion artifact, which obviously is important for image quality. Really critical aspect of vertical field scanners is we're able to scan physically large or morbidly obese patients because of that open architecture, and it serves especially for issues that may present when patients have claustrophobia or medical test anxiety, because a simple turn of the head to the right or the left and they can have an appearance of an open space when they're undergoing an MRI procedure. Another advantage is that it permits lateral or central positioning of anatomies into the center part or the sweet zone for the MR imaging, which improves the image quality in many cases. And you have the ability to do MR-guided procedures or interventional procedures such as breast biopsies, neuro procedures, which are driven and can be modulated and monitored directly with these MR-guided applications. So there's a lot of well-known and accepted advantages to scanning patients with a vertical field scanner. So the issue comes in with the fact that how do we manage patients when they present for an MRI? You know, the standard of care throughout the world is that you do screening of the patient. So there's a screening form. One of the ones that tends to be used is in its entirety or with slight modifications is the form that's on my website, mrisafety.com. And the screening involves this written form and then a verbal interview. And during that time, the technologist or the radiographer, or whoever is operating the MR system, identifies implants and devices that might be present in the patient, and you need to give those attention in order to ensure patient safety. I'm confining my lecture to passive implants, and these things are such as heart valve prostheses, orthopedic implants, and programmable CSF shunt valves. I'm not going to talk about active implants because, by and large, there's never been an active implant tested on a vertical bore system, with the exception of a couple of cochlear implants that were tested at 0.2 and 0.3 Tesla. Active implants are those medical devices that rely on their function from electrical energy or other source. So everything else that's not an active implant is essentially a passive implant. So these are the factors that impact passive implants when you're scanning with vertical field MR systems. First and foremost, we need to give attention to the field strength. So is it 1.2 Tesla or is it 0.2 Tesla? Then realize that the direction of the static magnetic field is different than what we have on a horizontal bore system. And then finally, there's the spatial gradient magnetic field value. I'm going to talk more about that, but that's something that's presented in the labeling, which you will usually see a passive implant stated that it's tested at 1.5 and or 3 Tesla, and then the highest spatial gradient magnetic field that was used to establish the force information for that implant. The next factor to recognize, and sometimes it's not given enough attention, is MRI-related heating. So anything that's a conductor, so essentially metal, and there are other materials that are also have conductive qualities, those things can potentially heat and cause a serious injury in a patient. And that's happened in many instances with regard to both passive and active implants. When we're looking at MRI-related heating, we need to understand what that transmit frequency is. And the higher the frequency is, the lower or the less the length of an implant is that would inherently result with what's known as the antenna effect or a resonant effect, where you can have substantial heating resulting in a burn in a patient. What our group reported nearly 20 years ago is that heating can be substantially greater at lower frequencies depending on the length of the implant. And that's something that's not intuitive to in many instances, unless of course you're an MR physicist, then you understand that entirely. With regard to these vertical field systems, the direction of those E fields being perpendicular, entirely different than a horizontal bore system. What has been reported in both passive and active implants is that the heating is substantially less. In fact, it's been reported that the heating is a couple of orders of magnitude less when you're imaging on a vertical field scanner versus a horizontal bore scanner because of the direction of those E fields. Another thing to recognize is there are certain implants that have operational components like programmable CSF shunt valves, and there are things like orthopedic implants that are magnetically activated. The functional disturbances can occur if you don't scan with the proper conditions in place. And then finally, artifacts are something that you need to recognize. They are typically less at a lower field strength and frequency compared to the higher field. So those are the physical factors that affect medical implants in general and vertical field scanners specifically. We have this terminology that was developed back in 2005, was adopted by the Food and Drug Administration and other notified bodies worldwide. This is the labeling terminology that's applied to medical implants, whether it's a passive or an active implant. MR safe is any implant or device that is non-conductive and non-metallic, and obviously non-ferromagnetic. And that includes things such as a Foley catheter with plastic, fittings, or Teflon otologic implants, or what you see here are shunt valves, which are monopressure shunt valves. Anything that's MR unsafe is something that's ferromagnetic or a device such as an active implant that's been demonstrated to produce an unsafe condition, such as having unintentional stimulation and or excessive heating occurring. So the lion's share of implants and devices have been tested and labeled MR conditional, and what you'll see is highly specific conditions applied that you need to follow in order to ensure safety for the patient. So this is how implants are essentially managed and handled with regard to the medical device industry. The manufacturer of the implant either does in-house testing, so they've hired medical physicists and bioengineers and those with a body of knowledge with regard to doing proper testing, or they engage in outside companies such as the one I'm the president of. Then the tests are performed for passive implants. We assess force, torque, we characterize artifacts, and we test MRI-related heating at a specific field strength and frequency. And by and large, that's always at 1.5 and 3 Tesla. And the reason is those are the predominant MR systems that are used in the clinical setting. So invariably, you will see labeling at 1.5 and or 3 Tesla only, especially for passive implants. Once that information is obtained, it's submitted to the Food and Drug Administration in the US or other regulatory body where it's reviewed, and if it's found acceptable, then the information is then presented in the instructions for use for the product, and there's usually an MRI safety information section in the labeling. That information, that content is then reviewed and followed by the MRI technologist or the radiographer to ensure safety for the patient when scanning a patient with a medical implant. Now, I mentioned earlier the spatial gradient magnetic field. I want to talk a little bit more about this because what we know and what has been demonstrated and what's been reported is that vertical field scanners, particularly the 1.2 Tesla scanner from Fujifilm, has a much higher spatial gradient magnetic field than a standard 1.5 Tesla scanner, okay? The 1.5 Tesla scanner, the spatial gradient magnetic field is around 800 Gauss per centimeter. The spatial gradient magnetic field for a vertical field scanner operating at 1.2 Tesla is 2,420 Gauss, so substantially higher value. But what are the implications and what's the importance of that? During the testing, when we're doing the force test, what we're doing is setting up an inverted protractor. We're suspending the implant by a string, a lightweight string, and it's freely able to move in space. And so for a horizontal bore scanner, this is what the setup looks like. This is the a patient table. The highest spatial gradient magnetic field for a horizontal bore scanner is right around where the opening or the entrance of the bore is. It's the same on either side. And at that point, where the highest spatial gradient magnetic field is, which is the patient accessible value, because there's actually higher values if you get closer and remove the outer coverings of the MR system, we're really interested in what the spatial gradient magnetic field is for the patient accessible areas. So that's where the test procedure is done, and we measure a deflection angle. And depending on what that deflection angle is, we will then either calculate or extrapolate what the value should be in the labeling. But keep in mind that implant is freely able to move in space. That never happens when an implant is used in a patient. There's always counter forces present. And the counter forces are basically the surrounding tissues and or any fixation mechanism. So for example, orthopedic implants are typically cemented in place and or they're screwed down or they're wired in place. Heart valve prostheses are sewed in place. Virtually every type of stent, when it's expanded in a vascular area, a vascular structure, it's positioned there and it's intended to be positioned so it's never going to move in the patient, even if it's a coronary artery stent and a beating heart and that type of thing. And so keep in mind that there are substantial counter forces that are always present when the intended use of the implant is there. And as such, that spatial gradient magnetic field really doesn't have any importance or relevance for the patient from a safety consideration when we're looking at force. Those counter forces are quite substantial and they prevent any implant or device, even if it was ferromagnetic, from being moved or dislodged in the patient present undergoing an MRI procedure on different MR systems. So I wouldn't get fixated on the fact that this is a high spatial gradient magnetic field with that 1.2 Tesla scanner, realizing the importance of counter forces that prevent any serious risk to be posed to the patient with regard to force aspects of the implant. Now, this is the situation with vertical field MR systems. You know, the instructions from use for virtually every company that makes these, and in fact, even for horizontal bore scanners, they always refer the operator, the MR system operator, radiographer, or MR technologist to follow the instructions for use for the medical implant. Well, that's all well and good, but realize, as I mentioned before, few, if any, implants have ever been tested on a vertical bore scanner, with the exception of a couple of cochlear implants that were tested 20 years ago. Our group did that work with several cochlear implants when we tested them on 0.2 and 0.3 Tesla scanners. Since then, I'm not aware of any other implant that's been tested and labeled specifically for vertical bore scanners. And so you may have information where the labeling says 1.5 or 3 Tesla or less. That was really outdated information and was unintended for application on vertical bore scanners. It was always with reference to horizontal bore scanners. And in fact, if you look at the instructions for use for those implants that state 1.5 or 3 Tesla or less, it may also state horizontal bore scanners only. So the manufacturers, as I indicated, and I've approached them, are not really interested in getting testing and labeling done for vertical bore scanners with respect to their implants. And as a result of that, there are many MRI facilities, and I know many of them in the US and in Canada and elsewhere, where if they don't have specific labeling for the implant or device, you're not allowed to scan that patient, and they refuse the MRI exam on a vertical bore scanner, which is terrible because it doesn't afford the possibilities of being able to scan obese individuals and other patients. They may benefit from exams on vertical bore scanners. So I worked with the American College of Radiology off and on over the years with their MRI Safety Committee, and this is their manual on MR safety that was published in 2020, where we have a statement that says, the final determination of whether or not to scan a patient is to be made by a level 2 MR physician responsible for the patient or the MR MD. Level 2 MR basically means that the individual, and that's either a technologist, radiographer, or physician, has the body of knowledge to understand all the issues that may be posed from a safety consideration, particularly with regard to medical implants. That information is what I presented to you before. Unfortunately, and I know many radiologists because I teach them, I train them at our School of Medicine, they don't get exposed to this information during their medical school, during their residency, during their fellowship. So they have to actively seek getting trained with regard to MRI safety, especially understanding the nuances of the issues that relate to vertical field scanners and those things that impact medical implants. So these are the recommendations and guidelines that I have taken all this information into consideration. So the decision to scan the patient should be made by a qualified supervising physician based on risk versus benefit. That means that individual needs to understand all the factors, the physical factors that can impact medical implants. And that supervising physician should understand all these different things to a level that they can make a competent decision on whether or not it's safe to scan the patient or not. Taking into consideration that you have a different direction for the static magnetic field, and with regard to E fields, the heating tends to be lower, and it has been reported to be lower for both passive and active implants. A margin of safety can be afforded the patient if you always scan the patient in the normal operating mode, which defaults the whole body SAR value to 2 watts per kilogram. This is something that can be adopted as general policy, and there are centers that have adopted this policy so they don't have to delay exams or, importantly, turn patients away unnecessarily. The possible exceptions are there may be some passive implants with functional components that need to be given more attention. So how did the radiologists get this information? Well, there's a lot of online training courses that are free, and there are also educational resources that can be tapped into where they can get the proper training and understanding in order for them to make these decisions for the patients. And so when patients come through the door with medical implants, and this is an actual image of a patient with multiple implants, you can make a decision to scan the patient or not based on risk-benefit. So for example, for coronary artery stents, we have, in fact, even general policies where every single coronary artery stent that exists can be scanned safely at 3 Tesla or less, regardless of the spatial gradient magnetic field or the direction of the static magnetic field, and that includes using vertical field scanners. We also have general guidelines for heart valves and annuloplasty rings, which are essentially the same. You can scan at 3 Tesla or less, regardless if you're using a horizontal or a vertical bore scanner. Whole body average SAR 2 watts per kilogram, maximum time 15 minutes per pulse sequence, and similar strategy for vascular access ports. So these are general guidelines that will speed up the screening process, and with adoption of this information, it's very useful in order to facilitate the screening procedure. I mentioned a few possible exemptions. Programmable CSF shunt valves need to give, special consideration, because with these devices, you need to determine the pressure level before the MRI and check and reset it afterwards. So there's more patient involvement when scanning something like that. And for things like magnetically activated implants, these are MR conditional, and there are specific conditions that need to be followed where there's a lower SAR value that needs to be adhered to. But there's no reason why you cannot scan a patient with those programmable devices, the CSF shunt valve or the MAGEC orthopedic implant, which are magnetically activated distraction rods to treat patients with scoliosis, as long as you follow those procedures. All this information is on my website, and I want to encourage you that if you can't find information or if you need specific answers to a particular patient issue, you can contact me directly, and I typically will answer you within a matter of 24 hours. Thank you very much for your attention.
Thank you very much. That was a comprehensive load of very useful information. If you have a question, it is the unique chance to talk personally. Any questions from the audience? So there's nothing on the line.
Shy, I flew all the way from Los Angeles for this chance, so.
Exactly.
Any questions? Yes, cardiac pacemakers. So I didn't talk about cardiac pacemakers or any active implants for that matter, but there are studies going on, particularly at Northwestern University, where they reported, as I mentioned before, this phenomenon that the direction of the E fields directly impacts the amount of heating that occurs is substantially lower, and they were studying deep brain stimulation systems. They are starting to study cardiac pacemakers now. You know, the problem is they can very well report this information in the medical literature, and it gives you some content, but what you don't see is the additional tests that need to be done on active implants, and that means looking for inadvertent stimulation. There could be gradient-induced heating that occurs. There could be gradient-induced vibration. There's a lot of other tests that are performed over and above what we do for passive implant evaluation. So there is now going to be a body of knowledge to follow, but this is one of those things that require a more concerted, risk-benefit analysis to include the cardiologists, the EP specialists in particular, that may need to program the device on and off. There is no MR conditional cardiac pacemaker that's ever been tested at 1.2 Tesla, but hopefully we'll see something like that in the near future, given the market share of the 1.2 Tesla scanners, which tends to be growing internationally.
There was one more question.
Yes.
Do you have the same safety management instructions for the perfusion scans as well?
For, I didn't hear.
Stress adenosine perfusion scan?
Yes.
It's the same.
Exactly. Yes. Other questions?
So basically,
well, I'll be at the booth at 2 o'clock. So if we have.
Basically, I would summarize as most of these devices can be orientated in the body in all directions of space. It should make no difference. What would be possible at 1.5 Tesla should also be possible at the 1.2. It's just at these edges where you have the strange gradients when the patient moves in. A very rough idea, if we talk about forces, torque working on at least magnetic devices, I would say 800 to 2000 something. That would be maybe 2 times, 3 times the torque that you could expect when the patient moves through this gradient. Is that, or is this too rough?
Well, so the spatial gradient magnetic field, there is some torque at the very beginning, but it's not substantial, and those counter forces will overwhelm just about anything. And the fact of the matter is, very few medical implants are made out of material that's magnetic to the extent where it's going to pose a hazard. And I'm talking about things like 304 stainless steel and that type of thing. By and large, medical implants are made out of titanium, platinum iridium, cobalt chrome, Phenox, I mean, all these low magnetic susceptibility materials. And thankfully, the manufacturers realize that, MRI is such an important modality that when they design their devices, when they select materials, they attempt to use low magnetic susceptibility materials to prevent issues with regard to force, torque, and of course artifacts. So that's important to recognize. That I can't think of many implants where that would be a problematic situation, with the possible exception of that magnetically activated distraction rod. And those are only put in adolescents, and they're not in very much widespread use.
Excellent. Thank you very much for coming all the way along and joining us here. Now we come to a very exciting thing which most users of Open Scanner will be not familiar with. We will have Dr. Marlon Olimulder. They are doing cardiac scanning on their Open Scanner, and I'm very much looking forward to an interesting journey into that field.
Thank you for the introduction. I'm excited to tell something about our cardio MRI results with the Open MRI. My potential conflicts of interest. This is the Oasis 1.2 high Tesla Open MRI. Since 2011, our diagnostic center Open MRI in Netherlands is in use. Initially mainly used for an accurate diagnosis of spinal cord, knee and brain problems in patients with claustrophobia and obesity. We are located in the eastern part of the country, State Overijssel and place Hardenberg. Since December 2016, I work as a cardiologist, and with my experience in the cardiac MRI, there was a desire to perform cardiac imaging on the open MRI. And therefore, in October 2017, we installed a cardio module on our Oasis 1.2 Tesla high open MRI in collaboration with Fujifilm Healthcare Europe. At this stage, this is the only open cardio MRI in use in the Netherlands and Europe. It features nowadays two parts. It is for patients with claustrophobia and are the obese. The open MRI is suitable for up to 300 kilos. Some demographics, up to 10% of patients is claustrophobic, and therefore we receive referrals from all hospitals, including university hospitals from the Netherlands, and even we had some referrals from France. The patient population from October 2017 until June 2022, we scanned in total 672 patients for cardiac MRI. Since we also have a closed-bore MRI in September 2020, yet 65 persons are referred patients. And of this total population, 5% refused or incompleted the examination because of extreme obesity, extreme claustrophobia, or technical issues. Maybe a patient has a lot of PVCs on the ECG, and that's difficult to do the MRI examination. Some patients' preparation. Before the study, the patients get or doesn't get any pre-medication, lorazepam or something like that. ECG electrodes are placed on the chest, compatible for MRI, and the peripheral venous line is injected for contrast injection. Some technical information of the open MRI. It's a balanced steady-state fast gradient echo. Repetition time is 3.7 milliseconds, and TE is half of TR. A body call or a flex body call, depending on the patient's weight and size, is fit on. It's ECG gated. Breath hold sequences are used, and the total examination time is up to 45 minutes when including the contrast enhancement images. Some post-processing. The DICOM images from user console are sent to MASMEDIS Suite 2.0. Some post-processing, assessing exact ejection fraction is very important to do to get your ejection fraction in a percentage. And the scar extent is very important to image. That's after the post-contrast images. And in our center, a radiologist reviews all images for potential extracardiac findings. The clinical indications for CMR continue to expand, but main indications are viability. After a myocardial infarction, the question is, are there revascularization options? I think it's the case in 40% of questions. Then an important question, non-ischemic cardiomyopathies, to see and to image the extent of fibrosis. In 30% of cases, maybe if there is sarcoidosis, Anderson-Fabry, myocarditis, or maybe ARVC. And an important question is assessing the exact ejection fraction. MRI has the current gold standard for assessing the exact ejection fraction. And it's often an indication for maybe ICD implantation as a primary prevention question. It's a question, I think, in 20% of the cases we scan at this moment. There are, of course, other indications in 10% of the cases. Is the aortic valve, is it bicuspid or is it tricuspid? Is there a case of an atrial septal defect? By performing a multi-slice, multi-phase 4-chamber view, you can perfectly image septal defects. In the case of myocardial infarction, if there is non-obstructive coronary arteries, is there also some scar or not? ARVC, echocardiography has often difficulties to image the right ventricle. So with MRI, you can perfectly show and image the right ventricle and see if there are signs of ARVC. And tumors. Together with my colleague Dr. Drost on the right side, we evaluate all cardiac examinations. And this is how it looked like in real in our center. And in the next slides, I would like to share with you some interesting images of 2 cardiac studies performed with our open MRI. The first case is a patient. He is 77 years old and he has ischemic cardiomyopathy. He had 3 vessel disease on the coronary angiogram. And the MRI question is, what is the exact ejection fraction and is there viability? Which means, is the patient suitable for some kind of intervention, PCI or CABG? Here you see the two-chamber view, anterior wall, inferior wall, and what you see is a diffuse hypokinetic myocardium with a bad LV function. Here you see in the four-chamber view, septal wall, lateral wall, with again diffuse hypokinesia with only some good contraction at the basal lateral wall. Right ventricle, you will see good contraction pattern. Also you see some tricuspid insufficiency. Interesting to show, open MRI can perfectly image the aortic valve. So you can also answer the question, is the aortic valve a normal tricuspid or is it maybe a bicuspid valve? In this case, the person had a normal tricuspid valve. This slide will show you the multi-slice, multi-phase short axis view. So you can see all walls, the anterior wall, septal wall, lateral walls and inferior walls from basal, mid and apical. Again, only there's some good contraction at the basal lateral wall. And then there show the cardiac function report. After tracing the end diastolic and end systolic slices on the short axis slices, you will get some information about the volumes, the end diastolic volume and the end systolic volume. And if you have that information, you can also get information about the exact ejection fraction. And in this case, it was around 35%. Then after contrast enhancement, you will get contrast enhancement images. And what you see over here, the anterior wall, there is extensive scar, distal anterior and also apical. When we go to the four-chamber wall, again there is transmural delayed enhancement, distal septal and again apical. And here is a slice of the short axis view. The mid-short axis view, and you will see anterior, septal and inferior. There is some subendocardial contrast enhancement. So in this case, with the exception of the distal segments, there is some viability, which means this patient could be a good candidate for intervention, PCI or CABG. Another case, this is a patient, 59 years old, and on echocardiography he has a thickened LV. And the MRI question is it LVH due to hypertension or hypertrophic cardiomyopathy? Again, first to show the two-chamber view, anterior wall, inferior wall. And what you see is a very thickened myocardium. Then the four-chamber view, again the left ventricle, the right ventricle. And what you see is on the left ventricle, when it's end diastolic measured, we measured a septal wall 21 millimeter, and normally it's about 11 millimeter. So it is a very thickened myocardium. Here again is a view of the short axis view with again the thickened myocardium. The function reports showed us a non-dilated but a severe hypertrophic left ventricle with a good left ventricular ejection fraction, 67%. There were no wall motion abnormalities. And then on the delayed enhancement images, there is patchy delayed enhancement at the right ventricle insertion points over here and also over here. And this is really a characteristic pattern for hypertrophic cardiomyopathy. So this is a case patients with diagnosis of hypertrophic cardiomyopathy. Besides, in these patients there was some reproducible patchy delayed enhancement apical in a not ischemic pattern. So in conclusion, open MRI with a cardio module offers patients with claustrophobia and or severe obesity a unique opportunity to get accurate insight in main important cardiac issues, e.g. viability, non-ischemic cardiomyopathy, and assessing exact ejection fraction. So thank you for your attention.
Excellent. Thank you very much. So, anybody questions? Is anybody working in an open scanner doing cardiac?
Question.
Yes, please.
Sorry, you mentioned 10% of claustrophobic patients. Is it figure for Holland or is it?
These are international studies, yeah, which not mean that the patient doesn't get, but 10% of patients has some form of claustrophobia. Mm-hmm. Yeah, yeah, so a lot. Sorry, I don't understand the question.
Can you speak up a bit?
Pediatric. It can be used for pediatrics, but in our center there is no experience with a cardiologist with pediatric, so that's why we don't do it at this moment.
More questions? May I ask you something? We just heard about the implants, and in the cardiac setting there are tons of stents and valves and something. What is your policy? How do you deal with those? Yeah, that's a difficult question, and we wish that everything could be scanned. But nowadays, pacemakers, ICDs, are yet not scanned with the open MRI. That's not a possibility. Stents maybe can be scanned. There's just a small artifact, so you can image the left ventricle, and you can get some information about the contrast enhancement. But it's a pity that for the pacemakers and the ICDs, yet we cannot scan. And our population, a lot of patients has pacemakers and an ICD. So we are waiting for results with the studies that maybe that's a possibility. That would be great. Fantastic. Any more questions? So thank you very much for this lovely insight into cardiac, because this is something we want to do in our place also in the future. So hope we can work together on that. And well, time to stand up. And have my presentation. Well, I will in the next minutes introduce our brand new machine, because it's just some sort of a first experience, because we're just having it only for a couple of months. And well, there's some observations which I would love to share with you. Of course, these are my conflicts of interests. And then we go, first question of you would be, where the heck is Groß-Gerau? Well, most of you have probably already seen Groß-Gerau, because you can see it from the plane when taking off from Frankfurt Airport. So we are sitting in the center of Germany. You can see close to Wiesbaden, Frankfurt, Darmstadt, Mannheim. And well, what is Groß-Gerau? Groß-Gerau is the county capital of course, Kreis Groß-Gerau. It dates back to a Roman castellum, so has some history. Population is 26,000. It's a young population, growing population, because it's a very active, industrially active region. It's not just the airport, it's also the big factories from Opel and many other companies there. So it's an active area. And of course, the most important thing about Groß-Gerau is the county hospital. Well, what is the trick about the hospital? The hospital is, of course, if you look at all the big sites around, we have 3 big university hospitals and also other large hospitals very close to that. A new MR system was needed. Additional external patients would have been a good idea to make it profitable. But what to do if there is already tons of high-end scanners, 3 Tesla and or even a 7 Tesla scanner in Heidelberg in the region? So something unique was needed, something which would be different from what is already there. And the solution was to think about a system that, what would the patients want from a system? What would people come to our site and get scanned? So the first thing is a pleasant setting, which is completely normal. Why? Well, how could a pleasant setting look like? Maybe like this. So it's a bit of with the wall images and the lighting, and the whole thing should be sort of very pleasant. So if there's competition around you, it's good to have a pleasant setting. Next thing is, most patients, not only the claustrophobic, but also the sort of feeling claustrophobic ones, would say a spacey open system, no tunnel. Have you been in the tunnel? That's the typical question that people would ask, your neighbors would ask, have you been in the tunnel or in the tube? So this is not a tunnel. This is a open thing, and you can see, well, you can, like this lady, you can stretch out your arms and sides, so there's space enough. Space enough. Patients would love that. And then comfortable positioning. Because many patients, they have pain and they cannot lie on the back, probably. They want to lie on the side. So you need a setting to get that done, for example. So this is a possibility in the scanner that the patient could lay on one side. And for example, when we want to examine the neck, they have this sort of solenoid coil. And those who are familiar with the MR physics here can nicely see a position of a coil, a solenoid coil in that position, like right here, would not work in a horizontal field. It just works in the vertical field because, of course, the coil has to have a certain direction to the field. Well, this is what the patient would see. It is a lovely seaside view, but the question is, yeah, what else do we have? Less noise. There's something I will show in a second, and well, no ejection, no needle. So angiography without contrast would be nice. Well, can we expect good image quality from this? So no, we're just looking on the patient comfort, so let's look on the image quality. This was taken with that solenoid coil. Of course, it does not offer parallel imaging because it's simply a solenoid, but it offers reasonable image quality, as we can see here in slight degenerative changes of the cervical spine. More images from this study. So there's a very good image quality that can be achieved with this while the patient is having a comfortable position. Same with the brain, again using that solenoid coil. If we go for the full scale head coil with parallel imaging and multiple channels, of course we can get slightly better image quality, but it's not that big of a difference. Again, but that coil has another advantage, of course. It uses with it works with noise reduction technology, so it's a very quiet thing, also something patients would like. And still, as you can see, as the detail on the left, on the bottom, you see the eyes of the patient. This is in the mirror, so at least they can look at their feet if they're lying in the standard supine position. So this is the kind of images you could get of the cerebral time of flight from the solenoid coil, which is, I would say, quite reasonable. This is what we would like to see. If we just switch to the other coil, now the standard head coil, of course, a bit better image quality, but still, for a simple solenoid coil, quite convincing what was done here. So they squeezed it very nicely to get a good image quality, even in that situation. Other tiny bits and details that are really helpful. Of course, you can also use that solenoid coil for the shoulder. We will see in a second why we would use exactly that one and not another one. But also you can shift the table to the side. So you can always put the peripheral joints into isocenter, which is something which can become very difficult. If you have a very spacious normal bore scanner, you can try. But you just put the patient in here and shift to the side to have it in the isocenter is really comfortable and produces reasonable images. So this is with the solenoid coil, a shoulder study. And we can nicely see that there's some inflammation at the acromioclavicular joint, while the internal structures of the joint are okay. Why did we use the solenoid coil here? This is the trick. We used it to use the Aber position. The Aber position, and we can see what happens here. Well, some people do, some do not use it regularly. Now we're using it regularly. This is the idea behind it. Why would we do the Aber position? This is from the literature. Because in this external rotation, the tendon of the long biceps muscle peels back, squeezes, moves the superior labrum, and then a tear that you could typically not see in the standard position becomes obvious. So this is the trick behind. And here you can see different examples of that shoulder, on the left in the standard, and on the right in the Aber position. And this is an example from the literature, where you can see how Aber improves the slap lesions, of course, and it squeezes the gap open, Pertus lesions, micro instability. So this is a nice example on the right here, where you can see how it peels off and it becomes simply more visible. So this is why many centers like it, and well, we simply didn't use it before because we had just a tunnel system with a 60 centimeter tunnel. Now, something new for us. Again, this lateral shift to the isocenter is very helpful when you do a wrist, because typically you imagine when we are using the 60 centimeter tunnel system, a good system, no way. But for that it was difficult because we had to position it outside the isocenter. Here we can nicely move in. On the photo it's a wrist. On the right we see an elbow. And just an example from the elbow, you can see there's excellent image quality. So this shifting to the isocenter means a lot. And for example, if you look at this image, when I stop here, you can see the inflammation on the radial epicondyle. In a case of epicondylitis, you can nicely see the cartilage, you can see the collateral ligaments. Well, those who do elbows very often and those who know about the trouble or daily work would love these images, I suppose. Well, of course, the lumbar spine, done with the with the system regularly where it works. The very nice feature is the water excitation myeloscanning, which comes out with a very reasonable image quality. We would, of course, see this, small disc material extruded under the posterior ligament. And another case where we can see the spinal stenosis resulting from that vast bulging of the disc, and we can get a very reasonable myeloscan. So we get what we expect from that scanner, what we are used to from the tunnel system. Again, you can see in this patient very nicely. I can use this pointer. Of course, you see the lumbar stenosis. You see the degenerative changes on with the liquid from the spondyloarthrosis. So, well, basically everything you would want to expect. Well, this is the problem. Be prepared. When you have such an open scanner, you will attract some patients who are not so easy to handle. In the US, they say large patients, to be politically correct. Yes, and if you look at this knee, because typically tunnel view radiologists, they look at the knee, you see everything you want to see. You also see this ACL tear, you can nicely see here. And again here, a lot of effusion around, everything you would expect. But just look at those images. There's a lot of patient around this knee. And this did not fit even in the, US size knee coil already. So there was used this sort of a blanket coil. It's a multi-channel coil that can wrap around. And this is the sort of equipment you would need because you would have to sort of handle this sort of patients. Another one, a nice shoulder image. If you look on the shoulder alone, focused like a radiologist, you would see, well, this is a good shoulder examination. For example, like here, showing the medial glenohumeral ligament. This is not a labral tear. Everything you would want to see, but just look how much patient is around this shoulder. It was again done with that. Well, it's a bit funny term, blanket coil, but this is a good description because you can just wrap it around. Another patient that was just done with the body coil of the system, so the inbuilt coil with the lumbar stenosis, and there's some nice effect that you would see. If you have patients of that size and you look at the lumbar spine, deep inside all that patient around, you typically have very weak signal, a lot of noise in the image, because of course they increase the signal, of course, to compensate for that, but this is a positive effect of the arrangement of coils and the vertical magnetic field that you can really get a wonderful signal inside these patients. So this is another plus for very heavy patients. A few words on metal artifacts. Okay, this is a very gross, very short version of what we just heard in the first talk, but of course, composition of the material, strength of the magnetic field, orientation of the material to the main magnetic field, of course, has a big effect on your image, and also imaging parameters, voxel size, echo train length. In our system, we have two advantages. The first is that the strength of the magnetic field is, well, it's still high field, but it's a bit less than 1.5, so we would expect a bit less artifacts. And then the orientation of the material to the main magnetic field, which is here vertical, makes a difference. Very nice study from the literature, where the magnetic field is vertical and you turn a screw. And of course, on the left, you can see that this is a screw. And very close to the screw, you already have normal image quality. When you start turning it, the more you turn it against the direction of the magnetic field, the worse your images get. And there you see screws, in fact. So the patient is just not lying in normal supine position. We basically have what we see here on the left. So the magnetic field is vertical. They are sort of following the magnetic field. And just look at how nicely you can see those screws here. And they can have full diagnostic imaging on these foramina. You see that there is a bit of disc material and other material here, sort of compressing that nerve root. And also, if you look on the cage here, look, you can even see the shape of the cage, because it's still not optimally, but nicely orientated to the magnetic field. That makes quite of a difference. Plus, and something from the literature, you have an open system, you can move the patient around. For example, in this case, where there's two screws for a tibial hip fracture, and you end up with an image like in the middle, you see a lot of artifacts, you can try and turn the patient a bit, and end up with a better positioning of the screws and a much better diagnostic quality in the vicinity of those screws. So size and shape of artifacts change with the angle to the direction of the magnetic field. Minimal artifact size if it's parallel to the magnetic field, as we've seen. And, well, with the angle, it gets worse and worse and worse with the proportion of the angle. So many materials are already in the body favorably orientated to the vertical field, and the open scanner helps you to optimize patient positioning. You can work on that and make that optimum. Last point, patients hate needles, at least many of them. Me as well. So what we can do about how can we do peripheral angiography at top image quality, as we see it on the right, with no contrast material. So this is a very sort of straightforward technology. It does nothing else than acquiring all images in a diastolic phase. Arterial blood is flowing slow, venous blood is flowing slow, you get a lot of signal from both. Then you take it in the systolic phase. Arterial blood is running through the vessel. It produces just a flow void, so arterial vessels are black. The veins, still slow, still a lot of signal. If you subtract both, arterials are left over. That was from the literature. This is from our own scanner. You can nicely see the diastolic images, both bright. Systolic image, just the veins bright. Subtract the veins, arterials remain, and you get this sort of image quality, which is very reasonable. The other way how you can produce nice angiographic images without contrast material is using an inversion recovery pulse. So on your left, you see just the imaging sequence with the bright signal of the vessels. On the right, you see what happens if you put an inversion recovery pulse up front of this. You turn the signal, turn the spins around 180 degrees, and on the way back, you wait for the moment when they are perpendicular, and when you have no signal from the blood. If you take an image exactly on that point, your vessels are black. And this is what's exploited in this technology. You can put the IR pulse over the whole field, and then take your image. So only the inflowing blood, that's the only thing that has not got this inversion recovery pulse and shines up bright. Next idea, same approach. You put the selective IR pulse upstream. So you take the image, then you take an image with the IR pulse upstream. So in that image, blood flows in which will not appear with signal in your image. You subtract, again what stays are the vessels. Well, great theory. Clinical reality is this. You get really sort of very impressive angiograms, which of course you can reformat them in any fancy way. So I am not the super reformatting fan. It's, I would say that is fancy work, but those are diagnostic images which I will look at. And you would, of course, why to use contrast material here if you can get such kind of images. Same for the carotids. Again, arterial spin labeling. Separate reconstructions, and around for the left and the right carotid. I think they give a nice idea what image quality we can expect from this. Another one, both carotids, a nice volume reconstruction. And of course, this just for notice, it also works, of course, in the thoracic aorta. There you go. And the next thing is, some people may know that I'm fanatic for thoracic MRI, in particular for the lungs. So we've done just a few shots so far. We will dig into this more in the future. And you can see on these Dixon images on the left already, if you look into the mediastinum, if you look at this, and you know what you're used to from thoracic MRI, typically deep in there, in particular if it's a bit more heavy patient, that was me, this one, you get a very nice signal there. Again, because of the ideal orientation of the magnetic field. It really helps with that. And it is also helpful, of course, for cardiac imaging. This is just the one and only we've done so far. Was very reasonable. On the top, we see something that we do, the running through scan is a free breathing scan that we do typically to exclude pulmonary embolism. You can see that the pulmonary vessels come with very bright signal. There is no contrast. There is just a free breathing examination of 1, 2, 3, 4, 5 minutes. You can do it in different directions, and you get a very fast examination of the pulmonary embolism. And on the right, you see some stir and some T1 fast spin echo reconstructions of the heart. So, all overall, what makes us happy about this? We're really having fun with it, because it's simply you get a lot of extras without compromises. You have a high field MRI with all that you can expect from it, but in truly open configuration. Of course, it's attractive for claustrophobic patients who come from far away to get their scans there. It is a solution for large patients. And you have additional benefits of the vertical magnetic field. We've seen examples for metal artifacts and that kind of very homogeneous signal, in particular that becomes important when you have large patients to have a good signal deep inside the patient. And in the end, it turned out to be something like a magnet attracting patients to our site, so books are full for weeks already. So, thank you very much for your attention. Any questions, please?
Could you give us any idea about the scan times you're using for the images you were presenting?
Roughly speaking, the same that we had with the 1.5 tunnel system before. It takes a bit more when you take that solenoid coil, of course. You can't use parallel imaging, but roughly in the same range. You can use the same schedules as you had before.
Yes, about the cost effective, is this similar, higher, or lower than a closed 1.5 second?
Well, if you look, you can get cheaper bore systems because there's more on the market and there's more competition in that field. The trick here is about the marketing is you get private patients. In German system, it's very important, and they come from far away, and it's a ridiculous thing in our state, in Hessen, in Germany. We have a federal system. The remuneration for a normal MR scan in outpatient practice is something like 68 euros or 70, something in that range. For a private patient, it is typically more than 10 times that. So if you're sitting in a setting and you want to run something like that, in particular in our system, it makes a lot of sense to attract them as well. Of course, we offer everything else as well, but that makes it effective. It is the setting.
Yeah, but then I mean also that the reimbursement, there's not going to make any change.
The reimbursement is the same regardless of the system you're using. I know that in other countries they have additional reimbursement for overweight patients. Was it France? I think they have that. Yeah, so it is looking at the system. It is not for free, of course, but it's cost effective because you can do everything you want, and if you have that additional effect of getting patients around, and what we haven't yet started is intervention. So I'm very much looking forward to do the facet joint infiltrations and the periradicular infiltrations in that thing, and that's fun. So the cost effectiveness comes with widening your spectrum and widening your scope of patients. Any more questions? So, thank you for coming. Thank you for joining us here. I'm happy to see you, and well, I'm there for your questions about the system, about everything that we have been doing. And well, don't forget to pick up your copy of the books, and you will have Professor Frank Shellock at the booth at 1400 to sign your books if you like. Yeah, the lunch is outside.